Hey everyone, welcome back to Izzy Medicine, where we take all the tangled corners of medicine and try to untangle them without raising your blood pressure. Today, we're diving into adrenal insufficiency, or in plain terms, when your adrenal glands just can't keep up with life. They're kind of like that one group project partner who disappears right when the stress hits. That's what they do. So, let's break it down. So first, to understand the abnormal, let's try to understand the normal. What do these adrenal glands normally do when they're behaving? They sit right on top of the kidneys and they look like little caps, small but mighty. The outer part, the adrenal cortex, is the real workhorse that produces the hormones. But here's the thing. It doesn't just do this on its own. It takes orders from higher up. This is where the pituitary gland comes in. This is our hormonal HQ in the brain. It produces a hormone called ACTH. And ACTH travels through the bloodstream and tells the adrenal cortex, hey, it's time to get moving, start producing those hormones. And when the signal hits, the cortex gets to work. The adrenal cortex produces three major types of hormones, and each from a different layer of the adrenal cortex. Aldosterone gets produced from the zona glomerulosa, and it controls sodium, potassium, and blood volume. Cortisol releases from the zona fasciculata, and this is our stress hormone, controls blood sugar, and inflammation regulator. And androgens like DHEA from the zona reticularis, they're not the biggest play here, but they do contribute to libido, puberty, body hair on a minor level. Now, when things go wrong, they get very, very wrong. We get adrenal insufficiency. But not all insufficiency is the same. There are two main types. And the easiest way to remember the differences is by thinking about where the problem starts. So let's review. Let's start with primary adrenal insufficiency, also called Addison's disease. This is where the adrenal glands themselves are toast, kaput, done, they're damaged, they're not working. It doesn't matter how hard the pituitary yells at them, they're not showing up to work, they're just lazy. The result, low cortisol, low aldosterone, low androgens, and high ACTH. The pituitary is working overtime, it's pumping out ACTH, practically begging the adrenal glands to respond, sending all that signal. But it's kind of like texting a disconnecting number, no response, just hormonal silence on the other line. So this is primary adrenal insufficiency. On the flip side, we have secondary adrenal insufficiency. And here, the glands themselves are still functional. They work, but they're not getting the memo. The pituitary isn't sending enough ACTH, so cortisol production drops because the adrenals are not receiving the signal. But here's the twist. With secondary adrenal insufficiency, aldosterone doesn't care about ACTH, so it stays normal. It's got its own system, the renin-angiotensin-aldosterone system, and it does its own thing. So in secondary adrenal insufficiency, cortisol is low, ACTH is low because it's not getting produced by the pituitary, but aldosterone is still cruising along just fine, so it's normal. Of course, both of these have causes, so let's zoom in on the main causes. For primary adrenal insufficiency, there are four usual suspects. The first one is autoimmune adrenalitis. This is the most common cause in the United States. Basically, the immune system gets confused and starts attacking the adrenal cortex. Specifically, it attacks an enzyme called 21-hydrolase. And that enzyme, it's pretty important. What it does is it helps the body make cortisol and aldosterone. So when it's under attack, production of these hormones tank. And the interesting thing about this is that this autoimmune assault doesn't usually act alone either. It's often part of a larger autoimmune package deal called APS2. And APS2 involves Addison's, Hashimoto's thyroiditis, and type 1 diabetes. So if a patient comes in who's a type 1 diabetic and they have symptoms of fatigue, salt craving, hyperpigmentation, all of which we'll discuss briefly, think about what other things might be lurking, such as Addison's disease. Next, tuberculosis. Tuberculosis is the most common cause of adrenal insufficiency worldwide. And weirdly enough, it's not just a lung thing. Tuberculosis causes cavitations in the lungs as part of its pathophysiology. So it can do the same when it spreads to the adrenal glands, and it slowly burns them out by cavitating them. By the time symptoms show up, the damage is done. So if our patient is immunocompromised or they're from an area where TB is common, we should ask about exposure to TB. Adrenal hemorrhage, or Waterhouse-Friderichsen syndrome, it sounds dramatic, right? And it is. Usually it's caused by a nasty infection with Neisseria meningitis, And as we know, this bug causes meningitis. But what it does, it also wreaks havoc on blood vessels. And because the adrenal glands are very, very vascular, wreaking havoc on blood vessels can trigger DIC, or disseminated intravascular coagulopathy, which is a condition of widespread clotting and bleeding. So what happens is when this hits, the adrenal glands hemorrhage and basically drown in their own blood. And the result is sudden adrenal failure and patients crashing fast with shock, a purpuric rash, and sepsis. Finally, metastatic cancer is another cause, and the adrenal glands, because they're vascular, they're a cozy spot for cancer to set up shop, especially breast and lung cancer. But this is the caveat. It takes a lot for the adrenal insufficiency symptoms to show up. About 90% destruction of both adrenal glands needs to happen before symptoms show up. So a patient might have adrenal metastases for a while without even knowing, and until the adrenals give out, and that kind of signals that they have metastatic disease, which is unfortunate. Now, let's swing over to secondary adrenal insufficiency. And this is where the pituitary gland is the one slacking. One major cause is hypopituitarism, and that can happen in a few different ways. One cause of hypopituitarism is Sheehan syndrome. It's a classic favorite on all kinds of board questions. During pregnancy, what happens is the pituitary gets bigger and more vascular. After childbirth, in Sheehan syndrome, if there's major bleeding, blood flow drops to the whole body, and in part, it drops to the pituitary as well. This lack of blood supply can cause ischemia and an infarct, and it causes the pituitary to die off. No pituitary, no ACH, no cortisol. With Sheehan syndrome, which we'll review later in a gynecology section, all the other hormones drop, so there are a myriad of other symptoms because the whole pituitary is damaged and causes what's called panhypopituitarism. Then there's pituitary apoplexy, a sudden hemorrhage into an existing pituitary tumor. So think of it as a pituitary stroke. The tumor bleeds, it swells, it compresses everything around it, and ACTH plummets instantly. And this leads to no response or no signal to the adrenal glands and no cortisol. Lastly, we have our macroadenomas. And what macroadenomas are slow-growing tumors, and they get pretty big, over 10 millimeters in size. And as they grow, they gradually squash the pituitary cells. There's no dramatic situation. It's just a lot of pressure. And over time, from this pressure and the squashing, the pituitary is not producing ACTH. It slips away, and we have the same end result. Weirdly enough, none of these are the most common cause of secondary adrenal insufficiency. So what's the most common cause? It's us. It's medical intervention. So chronic steroid use, when you give someone long-term prednisone or similar steroids, what you're basically doing is you're telling their hypothalamus and pituitary, hey, there's no need to make cortisol. We've got it covered. Everything is fine. And the pituitary listens. It basically understands that it doesn't need to create ACTH. It doesn't need to stimulate the adrenal glands. And ACTH production drops. And with that, because the adrenal glands are not stimulated by anything, adrenal glands quietly and slowly atrophy over time. So now we have these atrophied adrenal glands. Of course, we're not going to give patients steroids forever and ever. Some patients do need to be on steroids lifelong, but most patients get off of steroids. And when steroids are stopped suddenly, we're in a crisis. Hopefully we don't stop steroids suddenly, but if we do, that's a problem. The adrenals, because they haven't been stimulated in weeks or months, they can't jump back in right away, and we get adrenal insufficiency symptoms. So now that we've covered the normal, the abnormal, the reasons, let's talk symptoms. Because when these hormones drop, the body doesn't take it well. Patients with adrenal insufficiency really feel unwell. So what happens is we have a drop in cortisol, and low cortisol affects, as we know, nearly every system. Patients get really fatigued. It's like hit by a truck tired. Patients will sometimes say that. I am tired beyond getting out of bed. So cortisol normally keeps our sympathetic nervous system primed and responsive, and without that, it drags the system and the patient loses alertness and the stress response and the ability to adapt to minor illnesses, and they're exhausted. Then there's hypoglycemia. Cortisol helps raise blood sugar by stimulating gluconeogenesis from the liver and glycogenolysis. Without it, the liver can't keep up. Blood sugar drops because there's no sugar being produced through the liver and there's no fat being broken down into glucose. And the patients get hypoglycemia symptoms. They get shaky, they get confused, they get irritable. Sometimes they even pass out from hypoglycemia. Additionally, with cortisol helps maintain blood pressure. What it does is it increases the sensitivity of alpha-1 adrenergic receptors. What alpha-1 adrenergic receptors do is they help with vascular constriction, vasoconstriction. So when these receptors are less sensitive, blood vessels lose tone and they collapse, and we get blood pooling in the lower extremities, and we get orthostatic hypotension. Patients stand up and they feel dizzy, woozy, and they faint. So we have a tired patient, a hypoglycemic patient, and their blood pressure is low. They are feeling very, very unwell. And that's before even talking about aldosterone. So let's talk about aldosterone. So in primary adrenal insufficiency, if aldosterone is also missing, things get worse. Aldosterone helps the kidneys reabsorb sodium and water and helps the kidneys excrete potassium. So without aldosterone, what happens is sodium is not reabsorbed. It's lost in the urine, and water follows sodium. So not only do we get hyponatremia, we get low sodium in the blood, we also get dehydration because all the water is getting lost, and we get low blood volume. So the less volume in the tank, the lower the blood pressure drops. So in addition to the fact that the blood pressure drops because of low cortisol, it also drops because of lack of aldosterone. At the same time with aldosterone, potassium builds up in the blood because aldosterone normally tells the kidneys to get rid of it. Without that instruction, potassium stays in the bloodstream and it leads to hyperkalemia or elevated potassium. And aldosterone also helps excrete hydrogen ions. So when it's gone, the hydrogen ions stick around and cause metabolic acidosis. It's called type 4 renal tubular acidosis. But you don't need to worry about that. Maybe you do. But the main important things is that it causes hyponatremia and hyperkalemia. And lastly, some symptoms stem from low androgens. It's not a high contributor to the symptoms of adrenal insufficiency, but it can compound on the symptoms that are already there, such as fatigue from cortisol reduction. Here we can have fatigue from low androgens, low DHEA, low testosterone, and low estrogen. We can also have decreased libido. Women may also notice losing armpit hair and hair in general. So that's another symptom that we can pay attention to if we're thinking about whether our patient has adrenal insufficiency or not, in addition to the signs that we can find on blood work. Now, one of the most unique signs of primary adrenal insufficiency. Do we know what it is? It's hyperpigmentation. So think about John F. Kennedy and how tanned he was. He had Addison's disease. This is why hyperpigmentation happens. ACTH and alpha MSH, which stimulates melanin, both come from the same precursor, POMC. So when ACTH is high, like in primary adrenal insufficiency, alpha MSH is high too, and that gives us darkening of the skin, especially in the lips, elbows, creases, and scars. So now let's say you're seeing a patient who's tired, dizzy, craving salt, maybe looks a little bronzed and like they've been fake tanning. You're thinking, this smells like adrenal insufficiency. So now that you're thinking this, what do we do next? How do we figure out if they have adrenal insufficiency or not? Well, what we do is we start with a morning cortisol level, because cortisol naturally peaks in the early morning around 8 a.m. So if it's low at that time, it's already raising red flags of low cortisol. But we can't stop here. We can't just depend on low cortisol because it can mean a lot of things. So we need to figure out why it's low. Is it because of adrenal glands are broken, or is it because the pituitary isn't sending ACTH to tell them what to do? So we draw ACTH at the same time. So here's the logic behind this. If cortisol is low and ACTH is high, that means the pituitary is trying really hard, but the adrenal glands are responding, and that can signal primary adrenal insufficiency. If cortisol is low and ACTH is low, then the pituitary isn't even trying, and that can point to secondary adrenal insufficiency. So this is if our results are clear and simple. But like all of life, in medicine as well, patients' bodies don't read the book, and sometimes the results aren't totally clear. And sometimes we just want confirmation of what we found. So this is where the ACTH stimulation test or cositropin test comes in. This test is simple in theory. You give the patient a synthetic form of ACTH and see what the adrenal glands do with it. If the adrenal glands are functional and they just haven't been stimulated in a while, like in secondary adrenal insufficiency, they'll still respond and they'll pump out cortisol. But if they're damaged, like in primary adrenal insufficiency, they won't budge. Cortisol stays flat. So what we do is we measure cortisol level at 30 minutes and at 60 minutes after the injection. If cortisol goes up, the glands are responsive. If it stays low, they're done. They're cooked. Now, once you know whether it's primary or secondary and you want to dig for the cause, you're thinking, let's find what's causing this. If you're thinking for primary, you're testing for 21 hydrolase antibodies to look for autoimmune adrenalitis. You can also check aldosterone renin levels. In primary, the aldosterone is low and the renin is high because it's trying to stimulate aldosterone. You might also get a CT scan of the adrenals if you're thinking about TB, hemorrhage, or cancer, just to look at them and see what's happening. If you're thinking about secondary adrenal insufficiency, you get an MRI of the pituitary and you look for things like a macroadenoma, you look for apoplexy, you look for Sheehan's. And don't forget the most common cause, chronic steroid use. We always ask the patient, always. And sometimes the patient's history will point to that because we might have a patient that we know well and they have eczema or asthma or polymyalgia rheumatica or autoimmune issues and they're using steroids and they stopped suddenly without letting anybody know. So now that we know the symptoms and diagnosis, let's talk about treatment. But treatment comes in two types, acute type of care or chronic maintenance. But what causes acute issues? So like a lot of medical conditions, there might be a crisis of some sort, an adrenal crisis, a big one. This is where things really fall apart with adrenal insufficiency. It can happen when the patient with adrenal insufficiency gets sick, has surgery, trauma, or suddenly stops taking steroids. What do we see with an adrenal crisis? We see all the symptoms that we discussed, but on steroids. No pun intended. There's profound hypotension. It's almost like shock that doesn't improve with fluids. There's dehydration from the sodium leaving through urine and taking fluids with it. There's the hyponatremia because the sodium is escaping at massive amounts. There's hyperkalemia because potassium is getting retained and not getting kicked out. There's severe hypoglycemia because of all of these things, because of the low blood pressure, the low sugar, and the electrolyte imbalance. We can have confusion. We can even get to coma. We even have a fever sometimes because cortisol also helps regulate temperature and the patient gets febrile. If you don't treat this fast, the patient can die. This is a crisis of all crises. So now that we've encountered a patient with adrenal crisis, what do we do for treatment for this patient? First, we start with steroids, IV hydrocortisone, and don't wait for labs. If you think this could be adrenal crisis, just treat it. Next, we give support through fluids. It's very important to restore volume and blood pressure in this patient, so we give them normal saline to help them through the crisis. The third measure is dextrose. Cortisol helps maintain blood sugar, so without it, we need to give them glucose support because the body can't undergo gluconeogenesis on its own. Sometimes, even with fluids and steroids, the BP stays low, so we might need vasopressors as backup to help them maintain blood pressure. And don't forget to treat the cause, whether it's infection, surgery, whatever triggered the crisis, because if we don't fix the trigger, the crisis keeps cycling. Now, once the patient is stable, long-term management means replacing what's missing. So for cortisol, we give hydrocortisone. It's usually in 2 or 3 daily doses to mimic the body's natural rhythm. Some patients may use prednisone instead, but hydrocortisone is really physiologically a little bit more accurate. We also teach the patient about stress dosing because unlike a regular person who's producing cortisol and is able to regulate their cortisol levels on demand based on whether they're stressed or have an injury or illness, these patients can't do that, so we have to adjust it for them and teach them how to utilize dosing during times of stress like this. If they have primary adrenal insufficiency, they will also need fludrocortisone to replace the aldosterone. If it's secondary, it's not needed because remember, aldosterone comes from the renin-angiotensin system and is not tied to ACTH. All right, this brings us to a close of adrenal insufficiency. Great job for staying with me through all of that. I hope it was helpful. I hope that you learned. I hope that you found me mildly entertaining. If you like this lecture, please like, subscribe, leave a comment, share it with your study buddies. And until next time, keep learning and stay curious. Bye.